Welcome. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has been muted so they can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Lastly, at the conclusion of today's session, you'll be directed to a brief survey, which we'd like to ask you to complete. Your feedback is important to us as we plan future programs. So next, I would like to introduce you all to our guest speaker, Dr. Linda Kelly. Dr. Kelly is a doctoral prepared nurse and has worked at Mass General for over 38 years, focusing on women's health. Her role as an advanced practice nurse in the MGH Midlife Women's Health Center has promoted the advancement of patient-centered care and leading and directing of care for women within a collaborative environment focusing on multiple improvement work streams. She joins us today to give a talk on managing menopause and changes of life. So please join me in welcoming Dr. Kelly.
Thank you, Amy, and thank you everyone who might be here today listening. Today I'm going to discuss managing menopause and change of life. I'm going to briefly review stages of reproductive aging, midlife body changes, perimenopause and menopausal clinical issues, hormone therapies and non-hormone therapies, vasomotor symptoms, osteoporosis, genitourinary syndrome of menopause, breast cancer. So I'm going to review these different topics. As you'll see, each topic we could spend a whole day going over. So I've tried to pull out some of the real concerns that patients that come into my office have asked or have we've discussed. So I have no conflicts of interest. I'm going to start by the stages of reproductive aging workshop, which is called STRAW plus 10. This is a staging system. And this staging system was developed because chronological age is really a poor predictor of reproductive age because women just vary widely in the timing of the menopause transition. So the staging system was developed to provide consistent terminology, kind of standardization for the different reproductive ages, what happens in the different reproductive aging stages. It really looks at menstrual cycle bleeding criteria and also some hormone levels, specifically around FSH. STRAW came out actually in 2001, and there was an update in 2012, which would be STRAW plus 10 staging criteria. And I'm going to give you a little diagram of what STRAW plus 10 is. As you'll see, there's different for stages. There's reproductive stages that have early, peak, and late. Menopausal transition, which is early, late, and then menopause, late, early, and late. Down here are just this is the criteria for menstrual cycle and what happens during these menstrual cycles, and then some supporting criteria with the hormones. So perimenopause, what is perimenopause? Because women come in all the time and ask me that question. So it literally means around menopause. Perimenopause begins generally with abnormal uterine bleeding. Women can come in and have bleeding that's either longer than they're used to having, it's shorter than they're normal, it's intermittent, it's abnormal, and they can also have some symptoms like vasomotor symptoms, hot flashes, vaginal dryness, But primarily it's the intramenstrual cycle irregularities that'll bring somebody into the office. And then menopause is actually defined as the permanent cessation of menstruation. So natural menopause is a retrospective diagnosis. So it's 12 months of no bleeding, for which there's no pathological or physiologic cause to the amenorrhea. What happens in perimenopause and menopause? So almost every cell in the body is impacted or has some kind of estrogen receptor. So in menopause and perimenopause, where we see a decline in estrogen, women complain often around symptoms with their eyes. So one of the most common complaints is dry eyes, itchy eyes, irritation, feels like the pressure is something in their eyes. This is due, oftentimes it's just due to decrease in the estrogens. And we see the estrogen receptors just don't have that estrogen. So we can see a lot of these. There might be other reasons, such as environmental triggers, might be humidity. Today it's really humid, wind, autoimmune diseases. Sometimes in midlife and in menopause, women are on different medications. It could be diuretics, it could be antihistamines, psychotropic drugs. So we can see the changes because of physiologic changes because of the estrogens and the hormones, but we can also see it related to some of the clinical reasons or clinical therapies that these patients might be on. We see changes in the skin and the breast. We see dryness of the skin. We see thinning of the skin. We see photoaging, where we can see brown spots, rough skin, dry skin. The most common complaint is dry skin from aging. And this is due to decrease in water and lipid content and also oil production. We see breasts that lose tissue and subcutaneous fat. There's reduced breast size, fullness. Breasts tend to flatten and sag. There's a decrease in mammary glands, which also replace the fat tissue, making the breast less firm. We can see changes in the areola, hair changes, thinning of the hair, unwanted facial hair, which is hirsutism, thinning of the hair, and oftentimes is called androgenic alopecia. Odd thing is, the cause is usually unknown. It can be multiple factors that are impacting thinning hair. Can be genetic, nutrition, hormones, stress. Stress plays a huge part in this. We often see women complaining about hair loss during the menopause transition and postmenopausal. And again, these are caused by a variety of reasons. Female pattern hair loss is one of the most common. May be related to estrogen to androgen ratio, but there's multiple conditions can cause. We see vulvovaginal changes. So at menopause, we see a decrease in estrogens, like I said, and along with the associated changes, the vaginal microbiome increases the vaginal pH from an acidic environment to an alkaline environment. When we see that, we see that lactobacillus, which are actually protective, are replaced by other flora such as bacterial vaginosis. And then women can have vaginitis associated with these changes. Vaginal atrophy is thinning of the vaginal tissue. The vaginal tissue is thin, pale, it's very friable, it can bleed, it can be inflamed. Women will often have some spotting after intercourse because the tissue is very, very thin and fragile. Some GSM changes, which is genitourinary syndrome of menopause. We see that the urethra has estrogen receptors, and during menopause and perimenopause, the estrogen receptors were are not being stimulated, so the urethra can shrink. We can see an increase in urinary tract infections because of this, but also because of the vaginal pH that I described increases, and that can lead to colonization of bacteria. The strongest association for factors for urinary tract infection during this period in time for women are a history or a presence of incontinence, a cystocele, which a bladder that has prolapsed, history of premenopausal UTIs, diabetes, and just increasing age. Other symptoms might include vaginal dryness, dyspareunia, which is painful intercourse, dysuria, and urinary frequency. All of these are associated with the changes in the vagina around the epithelial lining, which gets thin. We can see a decrease in secretions from the vaginal glands. So lubrication becomes an issue with women. Women lose elasticity, and this can also impact their sexual function. The muscular tissue loses tone in menopause, which we can see women have prolapse of the uterus, the bladder, or rectum. And the last, with prolapse uterus and or cystoceles, oftentimes they're associated with women who have had vaginal deliveries in the past. Women come in because weight gain is always blamed on menopause. So some statistics, in the United States, 73% of women age 60 years and older are overweight. Women typically gain weight as they age. Excessive weight is associated with diabetes. And in studies that have controlled for age, menopause does not appear to influence weight gain significantly. So we have a discussion around that often with patients. Some studies have shown that increased weight in this period of time for women who have had a history of breast cancer have an increased risk for recurrence. And it may be due to the higher levels of endogenous estrogens. So although neither menopause or sometimes women who are in menopause that have hormone therapies is responsible for some added pounds for women. Studies have found that it's the visceral adipose tissue, so that visceral adipose fat that's in women's abdomen that convert to the adipose tissue, converts to increase in estrogens, where we can then see some clinical concerns around that. Cardiovascular disease, and again, breast cancer, potential increase with breast cancer. This is a chart that shows you that if you're underweight, that's not so good. Normal weight is 18.5 to 24.9 BMI, so body mass index, and this is how we divide your weight in kilograms by meters squared to get a BMI. If somebody's BMI is 25 or greater, we're going to work to counsel on some lifestyle changes. And if as your BMI increases, it might be lifestyle changes, it might be added drug therapies, it might be surgeries, things like that. So what can women do? Increase physical activity. As we get older, we just happen to slow down. Women will say they're active all the time, but when they come into the office and we really discuss it, they've slowed down since their 20s. So the recommendations are a minimum of 30 minutes a day, 5 days a week of moderate intense activity, 20 minutes of vigorous activity. Resistance exercise, this is great for improving bone mass. A healthy diet. There's no silver bullet anywhere for what's the best diet. It's whatever works for you. Weight loss management tools are actually, studies have supported that they can really be effective. Maintenance of weight loss is closely associated with a daily caloric deficit, so decrease of about 400 to 600 calories, regular activity, low-fat intake, and eating fruits and vegetables. Eating in regular intervals also is best practice for helping to maintain weight. Patients often will come in wanting to know about fertility in this perimenopausal stage. So fertility does decline with increasing age. We see a significant accelerated decline in fertility around age 35 to 38 and about 10 to 15 years before menopause. I will tell all patients that come in, though we see a decrease in fertility, you need to use protection. This is perimenopausal age is where we can see the highest number of unplanned pregnancies. So, and the reason for that is we already in perimenopause see changes in menstrual flow. So we see changes in your normal period. So sometimes they're longer, sometimes they're shorter. Women just don't know when they might ovulate. So they really need to use protection in this time period. Other causes that we might see related to abnormal bleeding could be other clinical reasons, polyps in the uterus, adenomyosis, fibroids, malignancies, excessive growth of the lining of the uterus, which is hyperplasia, sometimes blood disorders, and certainly ovulatory dysfunctions, which is we call anovulatory. Women just aren't producing an egg and releasing it. During this time, we see significant changes around cardiovascular disease. It's the leading killer of women. We can see palpitations in women. Palpitations are linked to lower estrogen. Vasomotor symptoms, hot flashes. We can see an increase in heart rate, anywhere from 7 to 15. And women feel that palpitation when they have their hot flashes. Other diseases may contribute to some of the coronary artery diseases in this age group, other cardiac diseases. Women can be anemic if their periods are very irregular and or very heavy around this time. Medications that women might be on, caffeine use, thyroid disease, and also anxiety. Some cardiovascular risk factors are hypertension, diabetes, high cholesterol, and obesity. Oftentimes patients will come in and they will tell me they have white coat syndrome for hypertension. If my patients come in and their blood pressure is elevated when they come in, that's real. And I really ask them to monitor and go to their primary care to really make sure that their hypertension, that they truly have hypertension, not just in the doctor's office. So vasomotor symptoms are probably one of the biggest clinical issues that patients will come in and want to talk about during perimenopause and menopause. So irregular bleeding would be one, and two are vasomotor symptoms. 10 to 15% of women have severe or frequent hot flashes. The hot flashes are second most frequently reported in perimenopause symptoms after irregular menses. So what happens with these hot flashes? There's a downward resetting of the body's kind of thermostat in their brain. The upper threshold is sweating and the lower is shivering. The hypothalamus, which is also in the brain, activates vasodilation and sweating. Women perspire. That evaporates, they get chilled. Women who smoke are likely to report more severe hot flashes than non-smokers. Black women report more vasomotor symptoms more frequently, and Asian women actually report the least amount of vasomotor symptoms. Night sweats are vasomotor symptoms that occur at night. Now, it's a cyclic event. Women have hot flashes at night, right? We see the core body temperature go up. We see increase in blood flow for the body. Women get flushed. Their heart rate goes up. Then it comes down and they shiver. That impacts sleep. That impacts their next day when they have to have their game on. So this is hot flashes can be very significant for women, and we'll talk a little bit about some treatments later in the talk. So what can women do to help with hot flashes? Well, first of all, what contributes? Warm environment, hot drinks, spicy foods, stress, absolutely. A higher BMI. We see cigarette smokers and alcohol. I'll ask women to pay attention to any triggers. These contributing factors we call triggers. What might trigger a hot flash? And see if you can eliminate that and see if they improve. Certain drugs can impact vasomotor symptoms. Other clinical diseases, thyroid disease, absolutely, infections, leukemias. And women who have severe hot flashes will want to come in and want their hormone levels tested. Serum estrogen levels none of the hormone levels correlate with any predictive frequency for hot flashes or where women might be in their transition. Partly because hormone levels are a snapshot in time, and it's that time whenever you drew that blood. So some of the hormone levels that are can be elevated when you take the blood test, and then the next day might just plummet down. So we see very dramatic swings in hormone levels during perimenopause. So they swing up. Somebody might be symptomatic, they might come down. So having blood tests really are not something that we would recommend. So lifestyle changes. I'll tell patients to keep your core body temperature as cool as possible. You want to dress in layers, sleep in a cool room, use a fan, maintain a healthy body weight, refrain from smoking. Exercise absolutely can help women. I often will tell them to exercise if you can in the morning, not at night. And then relaxation techniques. Studies really do support that these relaxation techniques help with vasomotor symptoms. What are some non-hormonal treatments for women with vasomotor symptoms? So there's different medications, antidepressant type medications like Paxil. There's which is FDA approved for vasomotor symptoms. Gabapentin is a medication that's off-label, but has definitely helped some women with their vasomotor symptoms. We increase it very slowly due to its sedating effects. Prozac, Effexor. And there's really good research that shows these antidepressants can help reduce hot flashes, but they also can help with some of the mood disorders that are associated in this transitional period, and also help with sleep. So what are some of the complementary alternative medicines? So these are what we call CAMs. It's just different philosophical kind of approaches to treating medicine, not the conventional medicine. So a therapy is called complementary when it's used in addition to conventional medicine. An alternative is instead. So some of these alternative medicines that are like our black cohosh that might help hot flashes. Flaxseed might help hot flashes. Ginkgo during PMS symptoms. St. John's wort, mild to moderate depression. Soy, hot flashes. Soy is probably the #1 CAM that has been studied. They're not FDA approved. There's most studies are conflicting. If a patient truly feels that they want to try some of these CAMs, I tell them, go ahead and try it. The thing you want to watch out for is you want to make sure that you don't have a cam that has multiple different ingredients, because if you're going to have a reaction, you're not going to know what you had the reaction to. Some terminology. So hormone therapy is replaced by what we used to call hormone replacement therapy. It is now hormone therapy. Within hormone therapy, there's estrogen therapy, which is estrogen that's used alone. It's called unopposed estrogen if a woman has a uterus. You can have estrogen that is at a dose that's systemic, so it goes through your whole body or your system, or you can have local estrogens, which are more localized, and they tend to be lower doses. And we'll go over some more of that through in the talk. There's estrogen progestin therapy. So progesterone is added to the estrogen therapy. It's added generally because we want to add it to the estrogen if women have a uterus, so it protects the uterus against endometrial cancers, where estrogen stimulates the lining of the uterus. It stimulates the breast tissue. It stimulates different cells in the body because, again, it's we have receptors throughout our body. So with estrogen alone, you worry if somebody has a uterus that it's stimulating the lining of the uterus to grow. And in theory, if uterus is stimulated, you worry that it will have increased growth, or what we call endometrial hyperplasia. Endometrial hyperplasia, if it's not treated, we worry can turn into an endometrial cancer. So the progestin counters the effects of the estrogen on the lining of the uterus. Women generally, depending on what type of regime they're on, may have bleeding if they're on a cyclical dose of progesterone. So if they take estrogens for a period of time and then have some progesterone, stop the progesterone, they might have what we call a withdrawal bleed. There's also bioidentical hormones. So these are hormones that are chemically identical or very similar to what's made in our own body. Patients come in all the time asking for bioidentical hormones. There's two available sources. There are bioidentical hormones that are FDA approved, and then there's unapproved or untested hormone therapies that are from compounding pharmacies. FDA approved hormone therapies are on this slide here. Estrace, these are Clemera, different estroderm patches. Prometrium is a progestin. We worry about non-approved FDA medications because there's no oversight from the FDA. What you get in one dose, you might not get in the next dose, or the next dose, or the next dose. So FDA approved medications are there for bioidentical, which a lot of patients will ask for. I'm going to talk just briefly also about the Women's Health Initiative. The Women's Health Initiative was a large study that began in 1991. It was funded by the NIH. There were more than 160,000 women who participated, and results from this study were released in 2002. This is a significant study because it was so large and it had such an impact in women's care, specifically around menopause and hormone therapy. The media did a really disservice to women when this first came out, because what happened was basically there were two arms of the study, an estrogen and a progestin arm, and then an estrogen alone. It was much more to the study, but the estrogen and progestin arm of the study was stopped early due to increase in breast cancers, stroke, blood clots, and urinary incontinence. So that arm of the study was stopped. estrogen alone arm of the study continued because there was not a statistically significant increase in breast cancers. When this study came out, a lot of women just stopped taking hormones. A lot of primary care stopped prescribing estrogens for patients. Since 2002, there's been a lot of diving into the Women's Health Initiative to really look at what the results showed. And what we learned from the diving into it is that the women in the study were much older than the women that we currently would start on hormone therapies. These were women around 59 up to, I think, 70 something, who started hormone therapies, both estrogens and also pills. So pills versus patches. So these were women that were older. It was oral estrogens and progestins. They started therapy well beyond the menopausal stage. So oftentimes they were 10 years out from menopause. And what we saw is that when you start hormones later in life, this is where we saw an increase in cardiovascular events within 1 to 2 years after starting. So it showed us that, one, we need to start women at an earlier age if they're symptomatic with significant menopausal symptoms, which we'll talk about in a minute. We want to have them on the lowest possible dose that we can put them on. And we want to have them on for the shortest amount of time that we can to help with their symptoms. So the formulation, the dose, the route, and timing of the therapy definitely produce different effects. And women can benefit greatly if they have symptoms of significant symptoms of menopause. We also learn that hormone therapy should not be initiated for primary prevention of heart disease and should not be initiated for chronic disease. And we actually have better drugs for osteoporosis at this time. So what are some of the pros and cons of hormone therapy and routes? So orals, one, they're easy to take, right? They're a pill. They have beneficial effects on some of our lipid profiles, our high density lipoproteins and total cholesterol. There's a tremendous amount of data that has gone on through the years to know that the safety, the risks and the benefits. They're generally low cost. We worry, and the cons are that there's risk for thrombosis, so clots, strokes, oral hormone therapy, oral estrogens can increase triglycerides, C-reactive proteins, sex binding hormones, thyroids. It can decrease free testosterone. And some of these changes in these hormone levels are significant for cardiovascular reasons and for sexual health, which we'll talk a little bit about moving forward. Estrogens come in, oral estrogens are systemic, so they go throughout your whole body. Vaginal estrogens tend to be more localized. So the benefit is that they're low dose, they're localized to the area of concern. Generally, it's the vaginal atrophy and vaginal complaints that women have. Some of the cons with vaginal estrogens are they can increase vaginal discharge. Some women just consider them less convenient because they're either pills, creams, or rings. And we do lack some long-term safety data, and so there's more going on looking at that. There's transdermal or topical estrogens. These are the transdermals. They avoid the hepatic first pass effects of the hormone therapies, so they have a less of increase in triglycerides and the C-reactive protein that the orals have. There are fewer GI symptoms. There is theoretical concerns, or that it's there's less risk for thrombosis and for blood clots than with orals. Some of the cons are the patch can be very sticky and might not stay on, might stay on too much. There can be skin irritations. The patch you put right around your abdomen and you move it every 3.5 days. So sometimes if you're in a bathing suit, it can be visible. It's usually a higher cost than POs. And the transdermals and topicals, well, the topicals come in gels, creams, and they can potentially transfer to others. So a significant other potentially could have a transfer of some of the estrogen component. Progesterones reduce the risk of endometrial cancers and in hyperplasias in women who have a uterus. We generally will dose progesterone at night because it can help with insomnia and improve sleep. If women are on the bioidentical prometrium, we have to make sure they don't have a peanut allergy because the oil that the prometrium is in is peanut based. Some of the cons is that estrogen progesterone therapy was associated with a greater risk of breast cancer in the Women's Health Initiative, though again, depends on what formulation, dose, and all of that. Some progesterones can reduce the beneficial effects that oral have on your HDL. Some women have bloating or PMS-like symptoms with progesterones. So treatment options for hormone therapy. So hormone therapy is an acceptable option for treating moderate to severe menopausal symptoms in relatively young, up to 59 years old women, or within 10 years of menopause. Remember, the Women's Health Initiative really showed us that the earlier we start women, if they're symptomatic, the better. Individualization is key to decision with hormone therapy. Talking with women about the risks and the benefits and your quality of life is significant. If your quality of life is impacted by some of these vasomotor symptoms, you need to have some treatments. And we know it can be safe given the lowest possible dose for the shortest amount of time. And quality of life is significantly improved. Women who still have a uterus need to take progesterone. Women who don't have a uterus can take estrogens alone. Let's see. Estrogens have been FDA approved for vasomotor symptoms and for vaginal dryness. Who shouldn't use hormones? Women with a history of breast cancer, history of hormone sensitive cancer, unexplained uterine bleeding, history of blood clots, known coronary artery disease, liver or gallbladder disease, and an increased risk in breast cancer is seen after around the 5-year mark with continuous estrogen progestin therapy. And again, that was what the Women's Health Initiative helped us see. So cardiovascular observational studies and reanalysis of the Women's Health Initiative by age or time since menopause suggest healthier women who are within the 10 years of menopause who have bothersome symptoms will benefit from hormone therapies, and the risks out the estrogen therapy or the estrogen progestin outweigh the risks. Quality of life, again, is important for women. GSM, which is genitourinary symptoms of menopause, comes in all different flavors. It can be vaginal dryness or irritation, increase in vaginal discharge, discomfort during sexual activity, urinary frequency or leaking of urine, and increased vaginal infections. There are non-hormonal treatments that we'll ask women to try. Sometimes we'll offer them to try some vaginal lubricants for sexual activity, vaginal moisturizers. Regular sexual activity actually is really good for GSM. It increases blood flow to the vagina, keeps the muscle, because the vagina is a muscle, just healthier. Some women will have what we call vagismus. So that's when the vaginal muscle contracts because of the fear. The brain is afraid of penetration and causing a contraction. So sometimes we'll work with women around vagismus and work with them around graduated dilators in the vagina, pelvic floor therapy, and worst cases sometimes of Valium in the vagina to help relax the muscle. Hormone therapy is effective for GSM. Local estrogens are absolutely beneficial for some of these women. They've also have helped with not only vaginal dryness, but some of the incidents of incontinence that some of these women have, and or some urinary tract infections. Systemic, it's a balance. Vaginal estrogens, we can see improvements. Systemic estrogens, we can see sometimes increase in symptoms. Low dose vaginal estrogens come in rings, tablets, and creams. There is non-hormonal treatment that is fairly new called osteoporosis that was FDA approved in 2013. Looks like endometrial concerns are not an issue. Hot flashes, we did see some increase in some hot flashes with these women, and we would use with caution in women with breast cancers and or clots. So some of the sexual concerns that women will come in, they're real for women at all ages. Some of the most common concerns are decreased desire or libido, decreased comfort or dyspareunia, painful intercourse. Some women have difficulty around this transitional period in perimenopause with arousal or orgasm. We can sometimes see that untreated depression or anxiety is related to some of the responses. Sexuality concerns there's no silver bullet, and they're very complicated. Because oftentimes it could be depression, it could be vaginal changes, it could be a partner with sexual dysfunction, erectile dysfunction, inability to maintain an erection, lubrication. Sometimes it's medication, sometimes blood pressure medications, depressant medications can all contribute to sexuality. Both systemic hormone therapy and low dose vaginal help to increase lubrication for women, blood flow to the vagina, and just that overall sensation in the vagina. If libido is concerned, we might, instead of oral, we might try transdermal because of the first pass effects in the liver. There's some antidepressants that actually have shown to increase libido in small trials. In non-depressed women, androgen therapies, which is testosterone, is not FDA approved for women, but some women we will treat with testosterone. We worry with testosterone around a women's lipid profile. They can, at high doses, you can see facial hair, acne, liver problems, and estrogen risk, because testosterone can be converted in the body to estrogens. Women will ask about intravaginal DHEA. The data with that is just really lacking, so I'm not somebody that would suggest that. The risk of breast cancer is very big with women who come into the office. They want to know about that. So breast cancer, it affects 1 to 8 women in the United States. Observational evidence suggests that hormone therapy doesn't increase the relative risk, which is important, of breast cancer in women with family history of breast cancer and or who have had a BRCA mutation. Some Observational studies suggest that micronized progesterone and other progesterones have shown to have a lesser impact in breast cancers, whereas other progesterones like Provera may have a more adverse effects for breast cancer. There are new therapies that are out there, which are called tissue selective estrogen complex therapies, and they have are related to breast cancer impact. Although they're looking pretty safe. They're new. Women with a history of breast cancer should not use hormone therapy. Systemic sometimes will add vaginal estrogens for patients who are very symptomatic and will work with their oncologist. I'm going to talk just briefly about osteoporosis. So here you'll see normal bone. This is osteoporosis. So osteoporosis is thinning of bones. It's diagnosed through a bone density and your T-score. Your T-score is normal at a T-score of -1. -1 to 2.5 is thinning bones, osteopenia, and to have the true diagnosis of osteoporosis, somebody's T-score, which is your total bone mineral density of your hip and or your spine. It's that total bone mineral density number compared to women at peak bone mass, which is in your late 20s. And so it's important for women, young women, to really make sure you get calcium, vitamin D early so that you have reserves. What we see in premenopausal and menopausal women is that premenopausal, the bone that's resorbed, so bone that's kind of getting eaten is getting replaced with osteoblasts, and it's stable. During perimenopause, because of estrogen deficiency, we see an increase in bone resorption. So osteoclasts are just, I tell patients it's like a Pac-Man eating the bone, and the osteoblasts that build are not in line. And so in menopause, perimenopause, we can see this because of the deficiency, but after menopause, the biggest decline is the first 1 to 2 years after menopause. The prevalence is huge. There's millions of women in the United States with osteoporosis or osteopenia. Risk factors are age. That's the strongest risk factor, increasing age. Low bone mass, anybody who's had a fracture, genetics, smokers. Women, we want women screened for bone density, postmenopausal women, 65 years and older, or if you're younger, but have risk factors, low body weight, history of a previous fracture, family history of osteoporosis, steroid use, and cigarette smoking. Treatments are selective estrogen receptor modulators, so SERMs. There's multiple different SERMs that treat not only bone density, but other symptoms potentially of menopause. Biphosphonates, calcitonin, calcium, vitamin D supplements, though your body absorbs calcium and vitamin D in your diet much better than supplements. Parathyroid hormones. All medications come with risks. With SERMs, we worry about clots. With calcitonin, women can have flushing of face and hands. Biphosphonates, you have to take a certain way because of esophageal issues. Calcium, nausea, vomiting, constipation. Vitamin D, we can see headaches. SERMs you want to take before you, once you get up in the morning, before you move. So with a large glass of water, biphosphonate, sorry. Calcitonin requires supplements of calcium and vitamin D, and thyroid, and with calcium, thiazide diuretics can also increase hypercalcemia, which we worry about. So in closing, I know, as I said, it's a tremendous amount, and I just very briefly skimmed over some of this, but menopause affects every woman. An unprecedented number of women are reaching midlife in menopause right now. There are multiple different ways to treat menopause, not hormonal and non-hormonal lifestyle changes, and there are risks and benefits associated with all of this. All right, Amy, sorry.
Thank you so much. We're now at the end of today's session. If you have any questions for Dr. Kelly, feel free to enter them in the chat. So we have a question on what effect does menopause have on mental health?
So that too could take a long time. So it can have a significant effect on mental health. Given the period of time where menopause and perimenopause hits women, it's oftentimes when you're potentially in a relationship that's wonderful, sometimes not. Sometimes divorced children are in the house, out of the house, back in the house. Parents may be entering back in. There's so many factors that it can affect mental health during that period of time. But then you put vasomotor symptoms on top of that, and you take the issues around sleep issues that are significant sometimes with night sweats. So menopause can impact significantly, and depending on where somebody is, your clinicians might recommend some of the antidepressants at a lower dose to treat your symptoms that then also will sometimes treat mood disorders. Some women who've had a history of psychiatric histories, menopause can make them worse. Changes in the hormones, in just everyday hormones during this period of time can make mental health issues either accelerated and enhanced, or they can sometimes improve.
Thank you.
What age?
On average, what is the age when women enter menopause?
Around 52 is the average age, though many women can enter in their late 40s, and some women can go into their 50s.
Thank you. And how often should one see their gynecologist?
Somebody should see their gynecologist annually. There have been changes in some of the preventative studies that we do, like a pap smear we may not do every year. But if a woman is perimenopausal or menopausal, coming in annually and having a pelvic exam really is important to make sure there's not any concern for any other pathology, ovarian cancers, things like that.
Thank you. How are estrogen and progesterone prescribed as far as scheduling and frequency?
So estrogens can be prescribed cyclically. So some women will have estrogens throughout the month and only have, 30 days. I'm making 30 days, and then they'll have 2 weeks of progesterone. That progesterone dose is a little bit higher if it's cyclical. Some women will have estrogens that they'll take estrogens and progesterones constantly throughout the month. A patch, you'll change every 3.5 days, but that's also through the month. So generally the change or the frequency is in the progestin. Sometimes it's throughout the month, sometimes it's cyclically. The other piece is some women might not do very well with progestins, and we might do an off-label IUD, which is a progestin IUD, so a Mirena IUD or a Skyla. that is off-label to treat the endometrium versus the pills for progestins.
Thank you.
Mhm.
Are there any programs or services available at Mass General for individuals experiencing menopause, help with menopausal symptoms?
Yes, there are. So I can get them to you, Amy. But Dr. Friedman here has actually, there's a few studies going on right now for mental health issues around menopause that I can also send to you if some of the people would like that. But yes, there are. So it's through our psychiatry department and through our Midlife Women's Center that they and Dr. Friedman is one of the key providers who provide that mental health.
Thank you. Aside from mental health, are there any other programs and services that covers all of the other symptoms of menopause?
So I think it would depend on what your symptoms might be. I know that the Midlife Women's Center does have and will have this year. COVID messed us up a little bit, but we do offer a community workshop that we'll have in September that addresses a lot of these different clinical conditions that are associated with menopause and or perimenopause that are at the community level.
Thank you. And if anyone's interested in these resources mentioned, feel free to email the Blum Center at pflc@partners.org, and we'd be happy to share that with you.
Great.
Is Celexa also used for hot flashes?
It's not FDA approved. It may be used. Again, some women are going to have improvement with some of these, and others won't. So it's not a first line medication that we would prescribe for that.
On average, how long do hot flashes last?
So hot flashes can last up to or greater than 10 years. Some women have no hot flashes. Some women have minimal or moderate, and it's when they have significant hot flashes that they tend to last a little bit longer. There's no way to predict that other than women should look at their mothers and how they went through menopause. That sometimes can help us sort out how long they may, but there's no tests that are out there that could tell us how long they're going to last, which is unfortunate.
Thank you. And I think we have time for just one more question. How about least invasive therapies, such as estradiol cream? How long to consider using them? Do you absorb creams and get some other benefits of oral meds?
Sure. So the estradiol cream is localized, and it's generally prescribed for women who have vaginal complaints. Women can be on vaginal estrogens forever, depending on why they're on it. Once you take away the creams, then because the estrogen receptors in the vagina aren't being stimulated through estrogens, then it will revert back to wherever it was. So it really depends on the symptoms of patients.
Thank you so much, Dr. Kelly. This was a very informative session.
Thank you, Amy.
Thank you, everyone, for joining us today. As I had mentioned, today's session is being recorded. So if you're interested in viewing the recording, you can visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Thank you.